Those of you who are online, welcome, and reminder to mute. And those of you here in Winslow, welcome to you. It's just nice to see some faces. Some people, I haven't seen in a year and a half. So my name is Sten Vermund. I serve as the Dean of the School of Public Health. And I want to welcome you to our Winslow Auditorium. This is the 9th jointly sponsored visiting speaker event. So started in 2012 and was created by Tom Gill, who is the director of the Pepper Center and of Yale's program on aging. Dr. Gill joined forces with my predecessor, Dr. Paul Cleary, in establishing this between the Pepper Center and the School of Public Health, which I think was wonderful. And this year, we're delighted to invite, to welcome, I should say, Dr. Ann Kurth, Dean of the School of Nursing, to formal co-sponsorship of this event. And Ann, we hope maybe that'll be precedent for all the future events, because really aging is a classic topic in which you're not going to draw boundaries between medicine, nursing, and public health. Those are going to be overlapping Venn diagrams in a big way. And that's how we started our Yale Institute for Global Health, because of that same logic. So let's do this together from now on. The purpose of the visiting speaker event is to enhance the visibility of aging-related research at Yale, and because of the distinction of our visitors, to enhance the prestige of research in this space. We want to encourage aging collaborations between the med school, the School of Public Health, School of Nursing, main campus, as well as across universities. We want to tell you just a few words about the Pepper Center and the Yale Program on Aging. That was established in 1991 to promote and facilitate interdisciplinary and interdepartmental aging research. A number of our faculty, Joan Monin, Becca Levy, and others are active members of the Pepper Center. And there are a number of folks from the nursing school as well. So it is across the schools. And resources were strengthened in the next year, in 1992, when Yale was successful in being designated a Claude D. Pepper Older Americans Independence Center. And many of you remember Congressman Pepper from Florida, who was a great advocate for aging research at the NIH and also attending to aging issues as federal policy. A number of investigators from different departments have been responsible for more than 55 field data management and analytics staff, and more than 80 research projects to date, including epidemiologic studies, randomized control trials, outcome studies, community interventional studies, and even molecular and translational investigations. So it's my pleasure to introduce my friend Tom Gill. Thomas Gill is director of the Pepper Center, professor of medicine, and is also directing Yale's program on aging. And he's going to introduce Sarah Zanton, our distinguished speaker today. Thank you.
Thank you, Sten. Gives me great pleasure to introduce Dr. Sarah Zanton as the 2021 Yale Visiting Professor in Aging. Dr. Zanton is Dean and the Patricia M. Davison Health Equity and Social Justice Endowed Professor at the Johns Hopkins University School of Nursing. She holds a joint appointment in the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. Her main research interests are in improving health equity among older adults, aging in the community, the effects of financial strain on health, and structural race discrimination and resilience. Dr. Santon co-developed the Capable program, which you'll hear about shortly. This program has been tested in randomized trials and now been rolled out to 45 new sites within 23 states in the US. She was the 2019 Heinz Award winner for the human condition and is a PBS organization's Next Avenue influencers in aging. She has published more than 150 papers, been principal investigator on more than $20 million of grants. Dr. Santon completed her undergraduate work in African American studies at Harvard University. And you can see how she's weaved that earlier training into her work. She's earned a bachelor's degree from Johns Hopkins School of Nursing, a nurse practitioner, master's degree from University of Maryland, and a doctorate from Johns Hopkins. She is core faculty at the Center on Aging and Health and the Johns Hopkins Center of Health Disparity Solutions. Dr. Santon's had funding from National Institute on Health, Centers for Medicare Medicaid Services Innovation Center, the Robert Wood Johnson Foundation, the Hartford Foundation, the Hillman Foundation, and the St. David's Foundation and AARP Foundation. 2 weeks ago, she was one of 100 new members who were elected into the National Academy of Medicine, one of the most prestigious organizations in the country. We are really delighted and honored that Dr. Santon, who's now a busy dean, is able to join us in person and talk with us this afternoon. The title of her presentation is From Clinical Practice to Disseminated Research Lessons Learned While Testing and Growing the Capable Program. Welcome, Sarah.
Thank you. Thank you so much. And I think I can take this off because I'm farther enough away from anybody. I promise I will not spit. Okay, well, so many of you all are people I really look up to and follow what you do, and it's really very exciting to be here, so thank you. And I'm a very informal person. We will have time for questions and answers at the end, a good chunk of time, but if something's unclear or you just want to argue, feel free to break in. And online, I think someone's keeping track of your questions as well. So let's start talking about equity. Probably a number of you are familiar with this graphic, but I just want to go over it for a minute. Equality is something we grow up with in this country with, thinking that's really important, and it is, but it's not enough. So if you look at the top line, everyone's getting the same bicycle, right? But it's not working equally well for everyone because she uses a wheelchair, he's too tall, she's too small, and it only works for her. And we tend to think like give the same opportunity for everyone, and that would be the same bicycle. But an equity solution takes into account what the person's needs are. And so she's got a smaller one, he's got a taller one, she's got one she can access given her needs. And I think a really good example of that we've all just lived through is when the vaccines first became available, you had to sign up with them on a website. And that was a very quick thing to do. It was the same thing for everyone, but we saw what happened. People who didn't have internet access couldn't get on. People spent a long time on the phone for their parents to sign up, and eventually we got to, okay, we're doing house calls for some people, and we're doing the primary care office for others, and that's where we really need to go. Is not just assume that if something comes out, that we put it out there and everyone can access it. Because one of the really key messages in health disparities and health equity is that new advances and new diseases widen disparities, right? You can see what happened with COVID. And when there's a new cancer treatment, that widens disparities actually because of who gets to access it. So that's a fundamental framing of all the work that I do that I think is really important. just briefly, I was a lobbyist before I went to nursing school. And so I think I've always been wanting to do policy relevant research. Once I got to be a researcher, I worked with migrant farm workers and adults experiencing homelessness. And I've always, looking backwards, I realized I've always been interested in the intersection of housing and health and how to change that. Once I was a nurse practitioner, I started in a home-based primary care with people who were homebound. And then I went back to get my PhD. So I was on the older side when I got my PhD, but it's all worked out. Here's another framing that I wanted to put into your heads. This is a little old, it's 2010, but by Dr. Frieden, who used to run the CDC. So the things to notice here are that you have more impact the farther down you are on this triangle. And importantly, the higher up, the more individual effort is needed by people to be healthy or by their clinicians. So in medical school, nursing school, we tend to spend a lot of time in this triangle and this triangle. So it's like what we do on individual level with people when they come to see us. And those are important. They're obviously important. But it's in here that we make more of a difference, right? We all know higher education, less financial strain, more opportunities, less segregation, improved health. They can sometimes feel overwhelming and sometimes feel safer to talk, well, how do I talk to people about stopping smoking? And obviously that's important, but we know that things like a tobacco tax actually decreases the start of smoking more than individual. So just as you're thinking about your work, the more you can get farther down these triangles, the more impact you're going to have. And so, we capable is kind of in between here, I would say. I'm just trying to get down in that triangle. Another sort of framing that I find useful, this is by John Auerbach, who was at CDC, and he was the head of the health department for Massachusetts. So this is kind of the very top of that triangle that we were just looking at. So if you think about 3 buckets of prevention, that these are increasing use of evidence-based services like ways of quitting smoking with patches or making sure people get mammograms. These are outside the clinical setting. So I would say capables in this bucket will be describing that. But there's other things that we might be doing. For example, innovative work in Penn where they're making more parks and getting down to light, looking at how that affects homicide, for example, would be in this kind of prevention. And then this, of course, is things like a tobacco tax or the COVID vaccine. But this, I think, can be a useful frame as we think about where our own research fits. So as I mentioned, I am a nurse practitioner, and I used to do home-based primary care. And I'm not going to spend so much time describing capable because I think it matters less than kind of lessons for your research, for whatever you're thinking about in your head as you come to this talk about what matters to you. So I'm just going to frame it enough so that so that the stories kind of stick. But so I was a nurse practitioner, and I've been trained, pretty traditionally. And I would go to people's houses, and the visits didn't have that much different content than they would have had if someone had come to see me in the clinic. So looking at their hemoglobin A1C and looking at their blood pressure and what are you eating? Are you getting any exercise? But I would, someone would open the door and they would be on their hands and knees because they couldn't get around their house, or they would be dropping their keys from the 2nd floor because they couldn't get down to the 1st floor to let me in. Or, I had someone who she would wheelchair around the house and then she would get on her hands and knees to get into her kitchen and grab stuff. So for those of you who have done house calls, I'm sure you've seen things like that. But, it made me realize, wow, the person's blood pressure is probably not the top of their mind. They're probably worrying about how they're going to get dressed or how they're going to bathe. So this is she was in our pilot, but she was very similar to people we had in the house calls practice that I had. And so, have people in the audience done house calls? Yeah. So you know what I'm talking about. And sometimes people say, oh, they're expensive. I would say they're priceless because you see what people are up against. You see their environment. You see the strengths. You see the family members who are helping. You see the neighbor who might be checking in. And so her bedroom was on the 1st floor where the dining room had been because she couldn't get upstairs. And you can see she's not really dressed. She's in kind of pajamas. She put on this hat because she was excited about the picture being taken. But this was her wardrobe. This was her clothing sense before we started Capable. You can see it's safety pinned together and broken. And because there's no closet in the dining room, right? The closets are upstairs where she can't get. And for her, she had very bad arthritis in her hands and congestive heart failure and diabetes. You know, not unusual to have, but so she was in her pajamas because she couldn't get to her clothes. And she sat pretty much all day in that chair because she had holes throughout her floor. This is after we fixed them. But she had holes throughout her floor and a 2 foot by 1 foot hole right by her front door. Like I literally had to kind of go like this, not jump, be in a hole at her front door. And imagine, you know, if you're older and your gait's a little different, she was probably safer sitting in that chair. But she was also, you know, deconditioning, and you know, none of us should be sitting all day long. These were actually not her steps; these were neighbor steps. But there's steps like this all over Baltimore. I don't know if you have these in New Haven, but in the 70s, a lot of people covered their stairs with different materials, and then haven't had the means to fix them. So, so let's just take a step back from Mrs. B. So in geriatrics, we know that there's something called the person environment fit, right? Where there's the person and their environment. And the ability to do what you want to do, it depends a lot on both. And creating the best fit. And not doing that as a society is actually really costly. And this is ignored in health claims because people don't code for disability. Right. And so it's hard, you know, if you talk to United or you talk to Humana or a big health system, and they'll say, how many of my people have ADL difficulty? You can't actually, you can know from prevalent data, but you can't tell them because they don't have it. People don't code for that. But there's extensive research over and over nationally showing that you're much costlier if you have functional limitations than if you just have chronic conditions. But if you look at the way services are developed, it's all about disease. It's about congestive heart failure. It's about diabetes. And it's when you have those plus some functional limitations that you are costing the health system a lot. And of course, we want to prevent all of that. Like, I'm not trying to make an argument that we should only care about people once they have functional limitations. But the lobbyist in me knew that I would be able to design something that was expensive and have people benefit and soon from a cost perspective. So in other words, if you're designing something for someone with diabetes in their midlife, that's really important and we should be supporting that. But you're not going to see the decreased costs within the next year or two, unless they're very fragile diabetic. Right, you're going to be seeing prevention over time, which is great. But the kind of strategic thinker in me was thinking to aim something towards people who are reliably expensive soon. And that way we can pull money out of the system and get it more on the prevention side. So that's basically what I was just saying. So Capable is 4 months. It's a handy worker, a nurse, and occupational therapist. The basic focuses are on activities of daily living and instrumental activities of daily living, although we also ask about meaningful activity, what matters to them, and other things I'll go into. And it's over the 4 months, it's about a $2,800 budget, about $1,300 of that is on the handy worker part, and 6 visits with an OT and 4 with a nurse. And overall it costs about $3,000. And that's still true. That number is from 2012, but the newer sites spend about that much. Some spend a lot more because they do roofs and stuff, but in general, it costs about $3,000. And so I'll just briefly explain it, but I could talk to you for 2 days about it. So it's 4 months, and it's the main thing. You know, if you walk away with only one fact about Capable, it's all around what matters to the person. There's no, because there are programs around the country where someone does an assessment and they say, you need to get rid of this area rug, and that's a trip hazard, and that's a trip hazard, and here's your assessment, boom, we're done. Capable is very on purpose. So we developed it with Laura Gitlin, who had been one of your prior speakers. It was based on her ABLE program. And Able was based this way, and then when we developed it as well, that it's completely based on what matters to the older adults. So if they're 85 and they smoke cigarettes, we don't mention the cigarettes. You know, if they're not taking their medications, we don't mention it. That's between them and their primary care provider, unless it's their goal, in which case we work on it. So the occupational therapist and the nurse both have assessments that are the same for everyone. So it's a universal assessment. But then they come up with goals based on what matters to them. And you guys are like the world leaders in goal aligned care and all of that. So I know I'm preaching to the choir, but there's nothing about Capable that we do without it being their goal. And in fact, in the pilot, we prioritized for safety first and then their goals. And I quickly learned that that did not make sense. Because if someone's in their home and they're there 24 hours a day, if they're slightly annoyed by what you've done, that's going to undermine everything else. So I'm just grabbing the water. And so they developed the work order with the handy worker with the OT. So that it's not just what the OT does an assessment, decides what you need. So this is just basically what I just said. And for clinicians, that's a big flip. You know, it's occupational therapists tend to be a little bit more like, this is why I went to occupational therapy school. This is what I've been trying to do. And it's different than regular practice, but I'm with you. Nurses, and I'm a nurse, I can say this, nurses tend to be a little bit like, what? You mean I can't tell the older adult what they need? And so we've developed, through the years, really robust training that's ongoing for the nurses and the OTs and Capable at these other sites. Because it does take us a minute. It takes about 5 clients before they really get it. And then it changes their practice with other people too, which is really exciting. So here's kind of a visual. So here's one possible goal someone might have that before Capable came along, they couldn't really cook for themselves. They couldn't prepare food. And so with Mrs. R, she wants to prepare meals more easily without shortness of breath and pain. And so you can see that's a good one for both the nurse and the OT. And so with the nurse assesses the pain, shortness of breath, and they brainstorm and make action plans around those, and also provides evidence-based strength exercises for strength and balance. And importantly, if we would come in and say you should do these exercises without tying it to a goal, the literature and exercise, people don't really do it. But if they've come up with a goal and what they want to be able to do, the exercises really stick. With the OT in this situation, the OT would assess and they would brainstorm together an action plan about the tasks and the functions. So maybe organizing things a little differently, what she can do for energy conservation. And in this context, it means her own energy, her physical energy, and then brainstorm about modifications. And so then in this case, the handy worker lowers the cabinet so Mrs. R can reach things and organizes the spices using less energy. And then a reacher to grab things better. And then an above stove mirror so she can sit while cooking. And, occupational therapists know all these tricks. I would never have thought of a above stove mirror, but that's, pretty classic for them. And so now she can make healthier foods rather than working, using packaged foods. And so that's just one goal. And so they get 6 because they get 3 with the OT and 3 with the nurse, and that they work on sequentially over the courses of the visits. And really key with this, and I know this is true with your all goal care too, is what you're doing is you're enhancing self-efficacy. So people often say to us at the end, oh, now I'm going to try to do this, and we are always reinstating that, like, this is the first of 6 visits, and then we're going to be doing this, and then you'll know how to do this yourself. So it's almost like the actual changes are just an engine for building self-efficacy. And importantly, the changes to the home are reminders of what they wanted to do. So for example, she'll see the reacher or she'll see the above stove mirror. Oh, right, I was going to cook sitting down. Or, you have a second banister on the stairs. Oh, right, I was gonna go up and down the stairs several times a day, or whatever it is. And so, in fall prevention, a lot of what Capable is injury prevention, but in sheep's clothes. Because a lot of times in injury prevention, there's a lot of don't do this and get rid of this, and you should have been doing this. And Capable is all around what someone wants to be able to do. But then it is making it a lot safer, and it's a government certified fall prevention program. Capable is based on the fact that the ADLs are safer. So here's just a visual example. Like, it's hard to believe that there are homes like this. 2 80-year-olds live in this house, and the last 4 stairs had nothing. And even if you just had an injured knee, that would be hard. So we almost all the time put in double banisters, and then of course everyone in the family uses them and loves them. So we were lucky to have Center for Medicare and Medicaid Innovation funding at the same time as we had a randomized controlled trial. And what that meant, and I was talking about this with some of the people earlier, was that we knew we were going to have the gold standard coming out. You don't want to make big changes to the world based on just a one-arm trial. But on the other hand, the CMMI money required us to be submitting results, reporting them as we went, because it was one arm, there was no control group, so you weren't blinded. And we could tell right away that it was a really powerful program just by the consistent, what we were seeing. But so this is from a one-arm trial, and you can see that 75% of people improved on their ADLs, and this is actually an undercount. This is people from who went from difficult to no difficulty at all. So it could be very hard to take a bath. And then at the end, they're like, yes, it's hard to take a bath, but it's a lot less hard, and we didn't capture that at all. So this is kind of an undercount. And on average, they went from having 4 areas of difficulty, 4 different ADLs, to 2. You can see the IADLs was a little less, but still good. And these are low income Medicaid eligible older adults with a few Quimby and Slimby, which is like low income Medicare. And it's over time. So even just staying the same, it's not too shabby, but they improved. And the depressive improved, and this counts people who weren't depressed at all to begin with. So, it's probably a little bit of an undercount. And I actually went through, because we weren't blinded, and we did spaghetti class looking at everyone with depression. So I wanted to decide who got worse, right? And then when I looked, people, there was someone who had got their home broken into twice during the 4 months, and someone else's son had died during it. And, there seemed to be real stories when people were getting worse. And of course, the home hazards improved because we were directly addressing it. We had the randomized control trial, which only came out 2 years ago. And we already had a lot of momentum from the one-arm trial. And so part of Capable's momentum is basically just luck that we were ready to write the grant for it when the CMI money was available. But we had basically similar results with the control group, with the randomized control trial. And the control group received also 10 visits, also at home, same amount of time, and also goal-directed, importantly. And so we worked with them about what would you like to be able to do, but it was sedentary goals. That was the difference. And so some people rewrote their mother's journal in their own hand. I mean, the goals were very interesting. Some people organized family reunions. This was, 10 years ago. So some people learned how to use a smartphone, or and at the time, the social attention visitor would say, you better be pretty strong on your side because I'm making a lot of progress with these people. And so we were glad that the control group, so you can see the control group improved as well. But on the ADLs and IADLs, the Capable improved more. And so this is this is basically the same view, just showing you the percent reduction. And now this is paper from CMS evaluators, and this is back to the one-arm trial. And so what they did is they matched every Capable person, they matched on age, gender, zip code, number of chronic conditions, healthcare spending up to 2012, and blanking on the last thing. And for the matches, they chose 10 people who were matched to each capable person. So for not being a randomized controlled trial, it's pretty robust. And they found per quarter per patient over 8 quarters. So if you multiply this by 8, you get this 22,000 number. And remember, capable costs about this much, costs about $3,000. So it's all, you could imagine it that it pays for itself in 1 quarter, and then there's 7 quarters of savings. And we were really surprised. We thought it would help with nursing home admission, but this difference is in hospitalization here. And this is misspelled. This should be state comparisons of control because this is the one arm. And so this is nursing home difference. And so this cohort of about 300 people, 2% of the capable people went to nursing home in the next year, and 5% in the comparison group. And just that difference in 3% was actually enough to pay for capable for the whole rest of the cohort. But the reason it saves so much is that we're also decreasing hospitalization. And Tom and I were talking about that yesterday. It's a little surprising. I'm not exactly sure the pathway of that, but one thought is, probably fewer falls, but, it'd be really interesting to know how much is the self-efficacy and the pain and depression versus how much is it just all together. The one category that increases is home health. And we figured that that's probably appropriate utilization, and it's probably mostly physical therapy, that there's a physical therapy screen on the first visit with the OT that triggers some referrals. And this is just showing that people really liked it. This is finding a great deal. And you can see, this is 100, and so a great deal of benefit made life easier. People really liked it, and the control group is in the orange. And this is, we were trying to go for that the control group liked it, benefited, and everything, which is great. But the bigger differences was where we were expecting, that made their home safer, healthcare for self, healthcare for others. So, for the people who are more junior, when you're designing a clinical trial, that's what you want. You want everyone to be glad they did it, and but you want to make sure you're creating real distinction in the active ingredients. And so for depression, for example, we thought the depression might help about similarly across, and that was okay to us because depression wasn't the main thing we were going for. So I'm happy to tell you a few stories of individuals, but I'm going to go on to kind of what we've learned and kind of growing it. But I'm always happy to kind of loop back to these as we get into the. But the impact is surprisingly strong, where people go from being stuck upstairs in their home to being able to freely go out, and happy to talk more about that. And as especially for junior folks, I would really encourage you to be collecting quotes and stories along with your data, because that's what makes a big impact for a lot of people. And a woman said this right to me: if I had 10,000 tongues, I could all speak at once. At the same time, I could not praise people enough. And I sometimes get like notes from people in Texas and stuff saying, "I wish I could hug you," but it's crazy how impactful it is. So I want to skip on to the kind of how it's grown and how we did that. But just to draw out some of the strengths. So why it works is this person environment fit. It's just key to all of gerontology. But until Capable came along, there wasn't much around the person and the environment and the fit. We tend to, put in grab bars or just focus on the person. And crucially, unleashing people's own motivation. People will call us and say, "Well, I'm done with Capable, but I wanted to talk to the OT because I have a new problem. I want to tell her how I brainstormed it." So there's just kind of this forward engine of movement that comes when people are done with Capable. And of course, we're honoring their strengths and goals. And then crucially, providing resources to achieve those. So we're not saying, "Oh, it'd be really great if you got an above stove mirror here." We put it in, right? Or it would be really great if you could get a pillow organizer that would help you with this. We give it to them. And that's in that handy worker budget. And so it's very different than just here's a referral for some things that could be useful for you. And we talked about the self-efficacy. So kind of just in summary, we talked about core functions costly. It's what we all care about, right? We all wanted to get dressed this morning and eat our breakfast and get here. And it's virtually ignored. But that's less and less true. I think people are starting to realize how important function is. And we're showing it can be modified. So it's kind of a perfect storm for growth, that it's important, it's costly, people care about it, and there's something to do about it. So Capable's now in 45 places, and it's about to be 3 places statewide, which we're really excited about, one of which is Connecticut and Colorado and Florida, and then Vermont is close behind. And you can see it's a really nice mix of, there's Meals on Wheels, there's hospital systems. Village MD is a really interesting primary care practice that's at risk, for money, and they're taking it on kind of as a gamble. And we're seeing the Visitor Service in New York, Habitat for Humanity. So there's, it's been exciting to us as watching it grow, because one of the clunky things about Capable is that it's not one organization by itself doesn't usually just do it, because you also need the handy worker. Occasionally places that hire, Yale could hire a handy worker to go to Capable, but usually it involves a partnership with a Meals on Wheels or with a Habitat for Humanity or a local group. And so that's exciting in terms of trying to grow things in the community, but it's harder. And at some point, someone's going to just make a Capable, an ability so that Humana or someone can just write a check to someone. Can you go to Capable? But right now, in the business world, they talk about buy versus build. Right now, if you do Capable, you have to build it. All these places have built a Capable program. At some point, someone will be offering it so that places can just buy it and say, okay, can you please do this? But these are all places that have built it. And so for this, I know you all know this, but I'm just putting it all in one place. We're gradually moving from a sick focus, which is the land we've lived in, to a health focus. And from a fee for service focus to from volume to value, so that health systems are needing to pay for population health rather than fee for service. And that's a big shift. And sometimes you hear people describe it as they've got their feet on a dock and on a canoe, and the canoe is like going away, and nobody's quite sure when to put the other foot in the canoe. And that a lot of health systems are kind of straddling both right now and figuring out, can we get people from other countries to come here so that we can, fee for service for them, or but that we're moving towards like focusing less on the process and more on the outcomes, and social determinants as being important. And so why all this matters to all the things that we care about is that we're interested in whole people and how they exist. And that's really on this side. But the fact that older adults, and especially functionally limited older adults, cost more money means that in gerontology, we can get more attention from the payers to solve some of those issues. And so with Capable, there have been a lot of constrainers that'll be on the next slide. The drivers to scale, for one thing, it's just common sense. It's just obvious. If you describe it, it's just clear. It's obvious. What's not obvious is that it would save so much money. And then we've got strong evidence. We've got much stronger evidence than a lot of silver sneakers and other things that happen out in the community. The second is there's just a giant need. You describe it to a congressman, and he says, "I want that for my wife." It's people. There's so little for older adults in the community. And I mentioned the policy shift towards value, and also towards understanding social determinants. And those are, of course, related, because back when all we were doing was fee for service, if somebody was hungry or they needed an air conditioner, that might be sad, but it wasn't your problem as a health system. Now it really is. And also the policy shift towards person-centered care, which you guys have been a huge driver in, that paying attention to patients as though they're people and as though what they want matters. And that with more and more, with the PCORI and more person-centered outcomes, and that the gerontology and nursing are great at person-centered care. And so trying to be able to talk the talk of the business people who have the money to broaden what we do as researchers. So some constrainers, so you could say, wow, 45 sites, that's amazing in 10 years. But it's only affected about 4,000 older adults, and there's millions and millions of older adults who have functional limitations. So the biggest constrainer, and we were talking about this yesterday, is there's no clear path to approval and payment for a collection of services. Right? If this were a drug, it would be a blockbuster, and it would be, people would be prescribing it right and left. Or if it were a stent or something, but there's no place where you go like the FDA and say, here it is. It's the results, okay now. And we did that with CMMI, we've done it with CMS, we keep going back and saying, we did it, it's time. People in Congress are writing a bill that's scale capable, probably won't go anywhere. CMS is, I think we'll talk to them for years. And really what's going to happen is that the Humanas and the Uniteds and the Medicare Advantages that have total cost of care will gradually adopt it, and there will be an inflection point at some point. But this is really a big constrainer for all the work that we do. I already talked about the underappreciation of function as modifiable. Another constrainer, as I mentioned, is it's housing and health. And so, if you're a health system, you don't really know who your partner would be that would do the handyman part. If you hire someone who I don't know about studs in the walls and what if there's liability. And so the housing and health, I think, is great, but it's also a real constrainer. And so this, you probably know about the wrong pocket problem, but I'll just describe it real quickly. So like, let's say you are a Meals on Wheels in Ypsilanti, Michigan, and you want to provide capable. You would be paying for the nurse and the OT and the handy worker, and that savings doesn't come back to you. So how are you going to pay for that nurse? So you're paying from the wrong pocket. But so in a value-based, so basically the trick to scaling capable is finding who's going to save the money and getting them to pay for capable. And even in Maryland, we have a total all-payer initiative for hospitals where they should want to prevent hospitalizations. And so Johns Hopkins Hospital actually does pay for a capable program in the community. But our sister hospital, Bayview, when I talk to them about it, they say, unless you can help me close a whole unit, you're not saving me money because I'm still paying for everyone who works there. And all I'm saving is the food that that person would have eaten. So they say to me, you're saving Medicare money, you're not saving me money. So trying to figure out, so for all of you who are developed stuff and you want to implement it farther, the trick is figuring out who needs to grow it, who it would benefit, and of course measuring the metrics that matter to them, which might not always be money. Sometimes it's nurse turnover or employee satisfaction or patient-centered outcomes. And then this, even though there is more social determinants focus, a lot of times it's for small things. It's for an air conditioner for someone with COPD. It's not $3,000. So, you show this to some people and they're like, that's way too expensive. Even though it saves so much and it's good for people, it's a frightening number for people. So we have had a lot of traction policy-wise, had now funds $15 million a year in Capable, which is pretty great. And a commission that advises CMS gave it unanimous. And Joe Biden, when he was candidate Biden, spent a whole minute describing Capable in a speech and went through the whole thing. And I was driving home from Alabama and my phone like blew up. But so, we're definitely getting places, but this is, so for all of you thinking about your own ideas, this is how I think about it, as that, the research environment and your idea are, I guess the seed, it's reversed. The seed is your idea. The ground is this incredible environment. You guys are here at Yale and we are lucky to have it happen, right? And that you've got people to go to. And when I first came up with Capable, it was just a nurse and a handy worker. And someone said, you need to go talk to Laura Gill. Great. We added that in. And so just the being around such wonderful people with resources and pilot money and all. And then, you start to grow it and you get a pilot, you get NIH funding, but that's not going to get you very far, except for in the journals, which is great. But then for getting bigger, it really helps to have some philanthropy. And the initial of that map that I showed, probably half of those sites are from foundations. And they tend to be local foundations where the place capable is. Some of them are national, like the Heritage Net, the Weinberg Foundation has funded a lot of capable sites. And so philanthropy is more nimble, their cycles are quicker. Once they get to know you, they say, what else can we do? You know, they're not like NIH where they're just sitting back waiting. But then to really be sustainable, you have to get the fiscal incentives aligned. You know, no one's gonna do sort of what they consider charity forever. And ideally, you get the fiscal incentives aligned and the policy environment right. So that you know, if there were a bundle of services payable under Medicare for capable, it wouldn't be hard to scale it at all. It would be much easier. People could come in asking for capable and someone could prescribe it and they could get it. So, you know, kind of this is where we all want to get. But getting to there, I think that I talked about this some in some of the meetings. I think we spent, as researchers, we spend too much time training our junior faculty and PhD students about what they are interested in and like a deep interest, which is important in research speak, but out in the world, it has to always be about who you're talking to, what their needs are, what's their problem that you're going to solve. And to do that, you need to think backwards or forwards about what you're going to measure and why and how from the beginning. So for example, I was advised early on to be measuring quality adjusted life years as my cost effectiveness. And from my lobbyist background, I couldn't imagine like showing to a congressional staffer and it saved this much in qualities, you know. So I just said, no, I know I'm really simple-minded, but I want to see how much it costs and how much it saves and if there's a difference. And they said, well, you'll never save more than it costs. Well, we can at least measure it, and then it did. And that is why it spread so much, because people are excited by that. Really thinking a couple steps ahead of if you're trying to scale something in a hospital or in a neighborhood, like who's got the power and what do they care about? And then measuring based on those things, and of course, what you think, like you're moving the science forward. But and I think I was saying this yesterday, I have an actual metric, you know, table that I make about who are the stakeholders and what kinds of data. For some people, it's quotations. For some people, it's stories. For some people, it's money. For others, it's, you know, what I said, like nursing turnover. And so thinking about that ahead of time, and you can always be adding that in as you go. So that's all. I guess for those of you who are clinicians, I think you're already really good at changing the world because you know how to talk to patients and families. And that's all other people are, right? We're all patients and families. And so, and I guess this is the last slide, just that I've learned if you want to be a rebel, you have to figure out what matters where you are and succeed in that. You know, like Tom read my biography, funding in this, papers and that, like that matters for sure in a place like Johns Hopkins or Yale. Get that covered, and then you can kind of do whatever you want in terms of going beyond. So that's all, and I'm sorry, I wanted to give you a little more time for questions.
Yeah, well, we have time for questions.
I got palpably excited when you said that Connecticut is going to be a statewide rollout. Could you explain exactly what that means?
Yes, so you used a mic, so I guess everyone heard the question. When the American Rescue Plan happened through COVID, people call it ARPA, states could add on to their Medicaid. They could ask for CMS for more money to Medicaid for different things. And 3 states asked for that for capable, and Connecticut was one of them. And so they're just now going back, and CMS approved it. And they're just going back and forth about wording and who are going to be the eligible providers and all of that. But it should be within 6 months or so.
What were the other?
Florida and California. Florida and Colorado. And Colorado has not just rural, but frontier, which we're excited about because there haven't been as many rural states.
Someone had no in the chat.
Yeah, Karen, are there any questions so far? Okay, for people who are
There's-
on the call, please feel free to put your questions in the chat. We have Karen monitoring.
Actually, I talk pretty loud.
Well, but the people on the, yeah.
That's true, people on phone. Yes, that was really terrific. Thank you, Sarah. My question is, you are prescient because what you have been doing before it was popular was equity and social determinants of health. And one of the things I think for junior people, when they're thinking what they do, they always jump on the bandwagon. But by the time they do that, the world has moved on. So how do you sort of advise? I mean, right now, the bandwagon is terrific. It's the right bandwagon that always should be there and always will be. But how do you sort of think about what junior people should focus on based on what may or may not be popular in the future by the time they get there?
Well, because I also focused on resilience before it was popular, that we had a theory on resilience published in 2010. And now I'm like, everyone get off of resilience. I think it really just comes down to values and interests. And that's what, like when I said, don't talk about what you're interested in. I think our interests are what really make us burning to go forward, right? It's like what keep us up and what makes us want to do this really hard career that we're all doing. So I think it's more about kind of looking internally than looking externally, but coupled with really listening to different areas about how they frame things. You know, and reading broadly, reading the New Yorker, reading the New York Times, listening to different, you know, like I listened to a podcast about complexity theory, and you know, just really trying to stretch your brain to other things, but then combining that with your own deep interests and what matters to you is just kind of how I've always done it.
I actually had a question for you. In terms of trying to get control, conditions for your behavioral interventions, how do you think about those? Because I always find that really challenging when you have a really great intervention. What are you comparing it to when you're trying to do something, that randomized clinical trials that drug companies are doing such rigorous work?
Right.
How do you do that in
Right.
behavioral intervention?
Right, so that's a great question, and it kind of goes back to Mary's question about kind of what's in vogue, because you can, what should happen in control groups also, there's styles to that, and what's in and what's out. So and things take so long to get funded, you might write it with one and then get it rejected with that, and then you get it with a different control group, and then by the time you go to publish it, they're like, oh, that's a bad control group. So it's a really hard question. We tended to, so I think Laura Gatlin was such a fantastic mentor, and she really helped me think about, well, what are the active ingredients and what are the inactive ingredients? So if you think about it in terms of a drug trial, like let's say there's a 3-ingredient blood pressure pill. And so those ingredients are the active ingredients, but there's also the act of taking the pill, right? And then remembering to take it, and maybe getting it refilled, and so that's why we have placebo trials right? Because people are remembering to take the sham pill. And so just trying to really think through what in your intervention is really active and what is kind of a side effect of it. So for example, with the attention control group, we were thinking, well, there will certainly be some benefit to people thinking, oh, someone's coming to my house today to focus on what I want. And even though we're sort of giving away the power of that in a way by having put in the control group also, it's not the core aspect of capable. So sure, we could put that in the control group. So social attention. I was a little nervous about putting identifying goals in the attention group, because I thought, well, that is really strong. But then I thought, you know what? If a research assistant who has a little bit of training in goal attainment can make a big difference in people's hospitalization, we need to know that. That would be amazing. So I kind of gave up the control on that. Like in exercise, fall prevention, a lot of times they do like sham exercise, and it's very understandable. It makes sense from a clinical trialist perspective. It also seems a little sad to me. We've also we're at a trial now in New York that Tom's on DSMB actually, and that they're getting nothing. It's post-hospitalization, and they are just getting like usual care, but there's no post-hospitalization usual care after home care. So in some cases, we've done nothing for the control group. But yeah, I think it's really tricky, and I would say, just talk about it with a lot of people, the design of your study as you're building it, because different people will have different critiques.
Aunt Kurt, you'd like to unmute yourself to ask a question.
Okay.
Yeah, thanks so much, Sarah. Really terrific talk and philosophy, really, of research. Appreciated it. And it just occurred to me as you talk about your data table that I really could envision us doing more of this at the earlier stages of our study design when we think about the data plan, because I think we don't think often enough beyond a dissemination plan of peer-reviewed journal article. Right. And you talked about the whole range, depending on your audience, you know, a legislator, an advocate, a funder, a consumer. And I just love that idea of think about the different types of data that might be germane to telling the story of what your study accomplished.
Thank you. And you making me think of another sort of piece of advice, which is just always be ready. You probably know this in terms of funding, but always be ready with an ask. Like if your dean came to you and said, if I've got a donor, $20,000, what would you do with it? Like, always know what you want the next thing to be and what you want. And and if there's any communication training here, take it, even if, you know, and take it over and over, especially if it does the horrible thing where they video you and you have to watch it later. Oh, golly. But, you know, any communication training, and this ethos, logos, and pathos, this is, you know, from back in Socrates' time, they've known that it takes 3 things to be compelling. And so the ethos is why we get introduced at the beginning. It's that you seem like an expert, you know, oh, she went to these fancy schools, I'm gonna listen to her, right? And the logos is the logic, so that's the data. Like if I just told you stories and I didn't have any data, you'd say, I don't know about that. But then it's the story, and I didn't really get to tell the stories, but the stories really stick with you. And so since the Greeks we've known, we kind of want all 3 of those, and we tend to train our people in just 2 of them.
So Dr. Santon, thank you so much for coming. We have a class
Okay.
waiting outside
Yep.
with students, but this was really wonderful and inspiring. Thank you.